So today we have Hamza Wajid, who is our PGY4, who is a cardiology resident with University of Toronto. His topic is artificial intelligence in cardiology, which is very dear to my heart as well. So let's move on to Hamza.
All right. Can everyone hear me? Okay, so this talk is on artificial intelligence in cardiology. I don't have any disclosures or conflict of interest. However, I did use ChatGPT quite liberally in making this presentation. Now, did I pick this presentation as an excuse to have AI do work for me? Maybe, but that's not something that can be proven. So the objectives of this talk is to present a high-level overview of how artificial intelligence technology is being used in cardiology. We're not going to get too much into the technical details of how this technology works. That would be a whole lecture series rather than a singular talk. More, I want to do a high-level view of different cardiology subspecialties, seeing the projects that are happening in those different subspecialties. So people can sort of see what might be coming down the pipeline, what projects you might be interested in getting involved in, things like that. We'll also discuss a little bit of the benefits, limitations, ethical considerations of implementing AI tools in cardiology practice. So just some basic terms. Again, this is really high level basic stuff, but just to make sure we're all on the same page, artificial intelligence is defined as anything being done on the computer that replicates human-like intelligence, performing tasks or decision-making processes that typically require human cognition. So you can imagine that's a very subjective definition. If you actually go into the literature about current machine learning models, whether they truly are AI. There's debate about it. Nevertheless, it's now becoming a colloquial term for machine learning models. A machine learning model is a branch of artificial intelligence where basically the algorithm is able to learn without you doing explicit rule-based programming. So, anybody who's done a basic programming course or even tried to put something into Excel, you know that you got to put some rules in and the program runs. Now, the idea of machine learning is that you don't need to constantly be updating the software or changing the rules. Rather, the software itself will learn and itself be able to solve problems. Artificial neural networks are sort of networks based on nodes, kind of simulating the human brain. Depending on when these networks are being made, depending on whether or not it's getting the correct answer, it'll make one node more powerful and weaken other nodes to try to get an answer. Deep learning is basically machine learning that uses artificial neural networks. And then the two big things I just want everyone to remember, large language models, that's the stuff that everyone's already seen. That's ChatGPT, that's OpenAI, that's stuff like that, which are basically using machine learning and deep learning to try to predict what would be the best next answer in a word format. Versus what's more being used in cardiology are conventional neural networks. Those are deep learning algorithms that try to analyze grid-like data. And you can imagine all images are grids because we've broken them down to be able to put them on screens through pixels, and then trying to find patterns in that data to find answers. So long story short, if all of that went over your head, basically artificial intelligence and these machine learning models are looking for patterns, are very, very powerful pattern recognition software. And then the idea is we take that strength of pattern recognition to answer clinical questions that might have been done by clinicians in the past or been done by other software in the past that really hasn't been able to answer those questions well. That's this one-liner of what this technology is. Now, benefits of AI in cardiology, I mean, you could think of this yourself, right? Enhancing your diagnostic skills, enhancing early detection of arrhythmias, heart failure, structural disease. We'll talk about all of that. Automating workflows, if you're in an echo lab, maybe making the workflow a bit easier, flow a bit better. One of the ones that is constantly reported in the literature as justification for these programs is improving inter-rater reliability, right? You might look at the same echocardiogram or look at the same cath, and people might debate what they're actually seeing. But having an AI software in the background that's quite reliable might allow for a consistent answer amongst multiple clinicians. And then finally, one thing that I've seen a little bit and might explode more in the future is facilitating more research with AI, whether that's basic research, basic science research, or chart reviews, where you can do big cohort studies by going through the chart and answering clinical questions, which in the past would have been the kind of thing a resident or a medical student would have done for a research project. So if that does take off, then I think a lot of us are going to have to look for new projects in the future, unfortunately. Now, risks of AI in cardiology. As with any technology, I think it's very difficult to say what the risks are at the beginning when it's only just being implemented. There's only a few programs that are FDA approved. If you went back 20, 30 years and asked people what's the risk of the internet, what's the risk of social media and things like that, they probably wouldn't be able to give you answers that are consistent with the issues we're dealing with today. So it is difficult at this point for anybody to really honestly say, okay, I know for sure what the risks of this technology are. But a couple of things that have come up. First is that as I've already mentioned, this technology is based on underlying pattern recognition. And if the data you use to develop the algorithm is poor, then your answers are going to be poor. And so the risk is that you have an algorithm or an AI software that you think is really good or really accurate, but ends up doing quite a poor job. So an example I'd give is, let's say you have an echo lab that maybe isn't doing the best job, certainly not St. Michael's, some other echo lab, where maybe they're consistently reporting ejection fractions under what other echo labs would say. Maybe when most people would say it's 40%, they're saying it's 30%. Then they train an AI model based off of their data. The AI model will look at the underlying echo images, will look at the results people gave, and will be trained on that. And the AI model itself will be consistently underreporting the ejection fraction. Then eventually they might think, hey, our model is great. Look, when we use it with our own data, it's doing a great job. But it's in fact doing a poor job because it's built off of poor data. Other issues that exist are stuff such as hallucinations. Hallucinations is when the AI breaks down for reasons we don't know and gives completely nonsensical answers. So if you go to ChatGPT and you ask it, name me the provinces of Canada, and it says Alberta, Albania, and Arkansas, it's had an hallucination. It doesn't really make sense. The issue with hallucinations is, one, they're random. We don't know how often they occur. Different AI softwares they'll occur at different times. And two, sometimes it's hard to distinguish if a hallucination has occurred. So you could imagine if you're using a software to give you clinical answers and it hallucinates and give you an answer that might seem correct, but really isn't, that could lead to a poor clinical decision being made. And then the final issue, at least on the first point, I'd say, is inappropriate usage is at risk with AI. So we're going to go through different programs that are being developed. A lot of them are screening tools. And we often see in medicine screening tools being used inappropriately. For example, maybe a patient gets H. pylori serology, which will tell you that you're exposed to H. pylori. Doesn't mean you have an active infection. And then a clinician might say, hey, this patient has an active H. pylori infection. Same with, a TST, skin test for tuberculosis. So we see this already happening in medicine, where a test that was designed for one thing gets used for a different thing. And the same issue can happen with AI, where AI software may have been designed to do one thing, but then clinicians might start using it inappropriately. So that's a risk that exists there. There's technical risks with the data. You know, Depending on the data you have available, you might have bias built into the data. We know that a lot of our underlying data sets are based off of, North American middle class individuals, maybe in the 1950s and 60s. We've been working for years to get better in that. But still, growth charts, upper limits of the normal, lower limits of normal are based off of data that doesn't really encompass everybody. And so if you use that data to make your AI software, again, you might very well be not representing all patients and appropriately looking at all patient populations. Thankfully, a lot of the research in this is being done in China. I've seen some being done in South Korea, some being done in India, some being done around Europe. And so the great thing is, as the economy in different countries have gotten bigger and have had more research ability, this issue should hopefully get better because you're going to have data from people all over the world. And then finally, there is an ethical and regulatory risk. What happens when an AI software gives you an answer that's wrong and a clinician uses that answer? Who's liable? Right? We already deal with these issues all the time. Usually it's a complicated topic. Usually ultimately it comes down to the clinician. But in the future, responsibility of liability could be something that's going to have to be discussed further, depending on what AI software, pretends to do or says it's able to do. So let's look at current applications of AI in cardiology. I would say if you find this presentation at all valuable, one paper I'd say to go to is the one that's being referenced here. This is a figure from Ellis P. who and colleagues who did a paper in the American Journal of Cardiology in 2024. You'll see it at the end of the reference, and they did a wonderful overview of different cardiology subspecialties, different ways AI is being used throughout these different subspecialties, and the limitations and future directions. So if you find this interesting, I'd say go to that paper. It probably does a better job than me explaining a lot of this stuff. So let's look at the different subspecialties. Let's start with electrocardiograms. I actually find this stuff to be the most exciting because it's taking a technology that now is more than 100 years old and pushing it even further in what we could do with it. That I find really, really exciting, taking such a simple test and pushing it further versus, the really more advanced tests we have and the $1 million equipment we have. So the first one we'll look at is AI technology being used to improve arrhythmia detection. So a study I put up here as an example, it was a study where done in China, where basically they took 180,000 examples of 10-second 12-lead ECGs. They broke down those ECGs into 21 rhythm classes, so stuff like, first degree heart block, ventricular tachycardia, atrial fibrillation, stuff like that. This was collected from 3 hospitals throughout Wuhan, China. And this information initially to train the software was annotated by a group of cardiologists. The model was trained on a conventional neural network, one of the things we had discussed. And the testing data, so excuse me, the original data was based off of what they had in their system. But then when they tested the system, they got a group of cardiologists to come and look at the testing ECGs and come to a conclusion of what they think is the correct answer. And then they compared their model to 23 cardiology physicians in the cardiology department, and they broke those physicians down by experience from 0 years to 12 years. So again, this is reiterating what I already said, 180,000 patients, ECGs from 70,000 patients was used to train it. And then they tested it on 828 ECGs on 828 new patients. The model was correct 80% of the time. The physicians, you can tell experience does matter. From 0 to 6 years, they were correct 67% of the time. From 7 to 12 years, they were correct 79% of the time. And 12 years plus, they were correct 75% of the time. So even the most experienced physicians were not as good as the AI model at picking up the arrhythmias in single 12 lead 10-second ECGs. The area under the curve of the model was 0.98 with a sensitivity of 0.86 and a specificity of 0.95. So really accurate model that was developed here that was outdoing a lot of the physicians in looking at single ECGs and picking up arrhythmias. There's also been work about pushing electrocardiograms to look for structural heart disease. So mostly this has been screening tests where there was one group in 2019 in Korea that developed an algorithm looking at ECGs to try to screen for patients with heart failure with reduced ejection fraction. So basically what they did is they took 55,000 ECGs from 22,000 patients across 2 hospitals. The patients had to have the ECG and an echocardiogram within 4 weeks. And then they broke the data down into testing data and data to develop the program, which we'll go into. They also added some basic demographics into the system, so stuff like age, gender, those sorts of things, nothing more advanced than that. And then the primary endpoint was, could the model, from basically looking at those basic demographics and the ECG, could it predict who would have a heart failure with reduced ejection fraction being defined as an ejection fraction of less than 40%. So this is sort of how they broke it down. They initially had 59,000 ECGs from 22,000 patients. Some were excluded 4,000 because the information wasn't well labeled. They had this from 2 hospitals. One was a teaching hospital, one was a community hospital. All of the ECGs in the community hospital were used to test the model, not to develop it. Of the ECGs at Hospital A, the teaching hospital, 20% of those ECGs were taken to develop the model, 34,000. The rest were used for internal validation. And then in Hospital B, the model was tested with the ECGs over there. So what they found with an area under the curve was that in their internal validation, the model was correct 0.8% with an area under the curve of 0.8, and external validation was correct at 0.8. They also compared other metrics. So part of their paper was about, okay, well, we're using a deep learning algorithm. What about other algorithms that were available in the past, logistic regression algorithms, random forest plots, and the model outbeat them that time. So basically what this is saying is that for a high percentage of patients, in theory, you could take their ECG and predict what patient is going to have an ejection fraction of less than 40%. Now, the model doesn't tell you what it's looking at in the ECGs to tell you that. So in structural heart disease, there's other work being going on. So as we're talking about detecting asymptomatic LV systolic dysfunction, as in this case from ECGs, there's models for identifying patients at future risk of heart failure progression. There's models for using ECGs for finding hypertrophic cardiomyopathy, cardiac amyloidosis. Again, we already have parameters on an ECG to try to make this diagnosis or tell us they might have this, but seeing could this be pushed further with AI models. And then finally, finding valvular heart disease, try to screen for that again from just a basic 12-lead ECG. Now, in terms of future directions of where this technology with electrocardiogram can go, I think a really important study is the Eagle trial, where they took one of these AI models and they gave it to a bunch of clinics. I think it was almost 100 clinics. And they said, okay, use this model. And they broke it, half the patients, half the groups used the model, and half the groups didn't use the model. And then they wanted to see ultimately what would happen in terms of people's clinical practice. With the AI model, there was a moderate increase of patients getting echocardiograms. So with the group that didn't use the AI models, 38% of the patients got an echocardiogram, versus the group that did use the AI models, 49% of the patients got an echocardiogram. But of the overall, the number of left ventricular ejection fraction patients that were found went from 1.6% to 2.1% in comparison of the two groups. So long story short, what this is saying is that when patients are seen in a clinic that is specialized in finding patients with heart failure with reduced ejection fraction, and they're using this AI model, it really doesn't increase the number of patients that are caught with heart failure with reduced ejection fractions. Basically, clinicians already have the ability to catch most of these patients looking at all of the other parameters we always look at. It's not really changing practice here. The number of patients that were caught who wouldn't have otherwise been caught wasn't all that high. So there's a couple of reasons for that. It could be that the models that were being trained aren't really generalizable to the underlying population, right? If you are training a model on all patients who come to a hospital who get an ECG and then an echocardiogram, well, you're already self-selecting for a group of patients who are much higher risk of having a low ejection fraction, right? As compared to the average person walking down the street, if I pulled them on the side and did a 12-lead ECG, that person is much less likely to just be walking around with heart failure with reduced ejection fraction. So the model may only be really good at finding patients with a high pretest probability, screening for patients who already have a high pretest probability of heart failure reduced ejection fractions, meaning its real world viability is up for debate. Like if it's supposed to be a screening test, how helpful is it if it can only screen for patients who are already at high risk of heart failure with reduced ejection fractions? So that I think the important feature to take away from this is that sure, the AI model might be able to screen for patients using ECGs for heart failure reduced ejection fractions, but does it really make a difference in the real world? The one big trial I was able to find for that didn't really show a big difference. So nevertheless, in terms of future directions, there is FDA approval going on for two models, one for detecting hypertrophic cardiomyopathy with ECGs and another for this very thing, finding screening for patients with low ejection fractions with ECGs. So there are currently two models that are being in the process of being approved by the FDA. Other future directions in terms of this technology, well, we have wearable devices. We've had multiple studies now, the Apple Heart trial and stuff like that in terms of wearable devices and their how useful they are at identifying underlying arrhythmias. But now, if you add artificial technology on top of that, how helpful that will that be? There's also work being going on in real-time telemetry monitoring, rather than the nurse having to look at 30 ECG strips at once, lead two, and trying to figure out who's going into VTAC. Could these models be better at picking that up as compared to what we have right now, which is it's always beeping, is always an issue, and you get fatigue from the beeps. And then finally, in terms of future directions, there's now bigger models going on for combining ECGs, echocardiograms, and CT data for more diagnostic power for answering clinical questions. So that's the work that's being done on electrocardiograms. Now we'll move to echocardiography. That sort of breaks into two groups. One is image acquisition, and that's what we're going to talk about right now. And the other one we're going to talk about is image analysis. So there was a study in JAMA in 2021 saying, can we improve patients, sonographers' ability to get adequate images using AI models? So basically, could you take someone like me, a first-year cardiology resident who has never really done echocardiography, until my next block, and could you make me useful at all? So what they did in this study is that they did it at two academic hospitals. It's a small study, so they took 8 nurses with no prior echocardiography experiences, and they were given an AI model that helped them orient their probe and get good images. Well, what the AI was telling was good images um, uh, uh, over a number of patients. They all scanned 30 patients, age 18 years and older, and then a sonographer who has experience came and did a similar, a full echo study on these patients without any AI guidance. And then they attempted to see how good were the images that these 8 nurses with no prior echo sonography experience, how good were they able to get images? Were they readable as compared to the sonographers with experience? It was limited. It wasn't a full echo study. It was basically looking at LV, ventricular size and function, RV size, and to assess for pericardial effusion. So more of a point of care ultrasound test rather than a complete proper echo study. And this is sort of their findings over here. And they found that the nurses, when you looked at the different, I don't know if you guys could see my pointers, but the nurses were pretty good at most of their assessments, those 8 nurses with no prior images. About 98% of the time, they were able to get good images, like 232 out of the 235 patients, they were able to get adequate left ventricular images to get left ventricular size, to get global left ventricular function, to get right ventricular size is a bit more difficult. They're only able to get it 92% of the time. But for somebody with no experience to be able to get these kinds of numbers is, in my opinion, really remarkable and shows how AI can be used to help out teams to try to get images that otherwise you just would never be able to expect somebody with no experience to be able to pick up the ultrasound probe and be able to get these sorts of results. So the other side of it is image interpretation. Um, uh, in terms of trying to figure out patients, trying to see, can AI help with image interpretation? And the paper that I found over here, where they developed again, as I mentioned, they're using conventional neural networks to try to figure this out. And basically, they were trying to see that could the AI model help classify patients with heart failure with preserved ejection fraction, which is typically a more difficult diagnosis to make with echo as compared to heart failure with reduced ejection fraction. And they had the AI model run on a number of patients, which we'll look in a minute. And then in terms of the control, they had a control group of patients with normal echo findings. And the model could basically give you 3 results. Either it says, yes, the patient has heart failure with preserved ejection fraction. No, the patient does not have heart failure with preserved ejection fraction. Or it could give you non-diagnostic saying, I'm uncertain, I don't know. It was trained on 2,971 cases, and there were 3,785 controls. And the model ultimately was found to have an area under the curve of 0.97. in training. And then ultimately, when it was deployed against the controls, it was found to have 0.95 area under the curve. So again, a pretty good model at finding heart failure with preserved ejection fraction. When they sent it for independent testing, they had 646 cases that an independent group used and 638 controls. And when they tested it there, the model had a sensitivity of 87% and a specificity of 81%. So still a pretty good model at finding heart failure with preserved ejection fraction um, uh, as compared to what we've had before, which is really nothing at all. So in terms of echosonography, future directions of where we could see AI going, simplifying image acquisition using real-time image guidance, as we saw in the first case, whether that's point-of-care ultrasound in the emergency department, on the cardiology wards, or just on internal medicine wards, having devices that can guide people to get good images that could be used by an echosonographer, or that could be used by anybody to try to figure out what a patient's ejection fraction would be. Other aspects that are being worked on is to improve the efficiency, as we were talking about already here. And finally, there's work being going on to use AI for detection of difficult to diagnose conditions, as we saw here. Heart failure, preserved ejection fraction is one of those conditions, and other conditions as well. So the last group I want to talk about, the last sort of cardiology subspecialty, is in terms of interventional cardiology, coronary angiography. There is stuff on cardiac CT, on cardiac MRI, and a whole bunch of other stuff, but I didn't want to bore everybody by going on forever. I was just trying to make the point of what these different models can do. And so I thought I'd end with coronary angiography to show that even our interventional colleagues are maybe not safe. So in this paper in Nature in 2023, they attempted to develop a model that could, well, let's go more into it. Basically, they wanted to create a model that could visually classify left heart catheterizations in 4 dimensions. First, the model could the model classify the angiographic projection? Second, from that projection, could it classify what anatomical structure are you looking at? Third, could it find the location of the stenosis? And then finally, could it predict the degree of stenosis? Particularly, could it detect severe stenosis, which they classified as greater than 70% stenosed? They used 13,000 angiographic studies at the University of California, San Francisco, from 11,000 patients. And then actually they sent it to the Ottawa Heart Institute to assess how it's being done over there, and to assess the model's reliability and its function over there. And then they sent it to the Montreal Heart Institute, where they retrained the model again with their own data, and then assessed the model to see could it work even better with the retraining in Montreal. So this is sort of a visual example of what the model was trying to do. So it looks at the left heart catheterization, it looks at each image and says, okay, well, what view am I first looking at? What projection is it that we're looking at? Then what's the anatomical structure? Are we talking about the right coronary artery, left coronary artery? Then it says, okay, breaks it down even further in terms of the substructure of the coronary artery. And then finally, the final aspect of it is, can it assess the degree of the stenosis? So it's basically 4 AI models running in one to try to get the answer over here. So what were the results? In terms of the angiographic projection, it had a positive predictive value of 0.9 and sensitivity of 0.9. Interestingly, they didn't report specificity. I don't know why in this paper, but nevertheless, pretty good at figuring out what the projection was. In terms of figuring out between the left coronary artery and right coronary artery, even better at a positive predictive value of 0.97. And the right coronary artery, a positive predictive value of 0.93. And then when they tested the model at different locations to find stenosis, how well could it predict stenosis greater than 70%? At the different locations in California, they had an area under the curve of 0.86. In Ottawa, they had an area under the curve of 0.86, so very similar results. Interestingly, in Montreal, after they retrained the model, and then they deployed the model, they found an area under the curve of 0.775. So I don't know. I tried to look at the paper to find why, the explanation of why the model did poorly after retraining in Montreal. Nevertheless, it did, and it again it does exemplify the point that these models are only as good as the underlying data. So I don't know what happened with the data set over there, but still pretty good at being able to find and answer these clinical questions, which are a very common question that a resident would get sitting in, cath rounds and saying, can you answer all these questions? And if you asked, what's my sensitivity, specificity of answering these questions, is much, much lower as compared to what this model gets. And the justification, their rationale for creating this model, it wasn't to say that they're going to replace anybody, but their rationale was like, look, there's a lot of inter-rater debate. Two people might look at the same left heart cath and might have varying opinion, especially when it comes to degree of stenosis. So having a model in the background that's relatively stable and relatively predictable can help a little bit to have at least a baseline that everybody can accept that, okay, the model is saying this, and then you go from there in terms of expertise of the interventional cardiologist. So future directions, what other work is also being done in terms of coronary angiography? One thing that was really cool, and again, I didn't include it for time, was estimating LV ejection fraction from simply just the certain projections in the left heart catheterization without the LV gram. So you can imagine, without giving that huge contrast load, there were models being developed to try to figure out, could we look at LV ejection fraction with various degrees of success. Dynamic coronary mapping, another aspect of trying to decrease contrast load, which is, could the model itself predict with a small amount of contrast where the coronary artery is going to go, and would an interventionalist be comfortable using that model? Basically, it overlays over the image to guide their wire. And then finally, AI analyzing plaque features to try to evaluate, which patients' plaques are more high risk, which one of these are not plaque, but rather thrombosis, what's a patient's risk of cardiovascular death with respect to what you find on left heart catheterization. There's been work being done on all of that. So the conclusion, again, I didn't include cardiac MRI or nuclear imaging or CT because, I think I would just belabor the point of there's a clinical problem, and AI is being used to try to answer that clinical problem. But there certainly is a lot of big work being done in these subspecialties as well. My concluding statement really would be that AI in cardiology is a rapidly growing, diverse field with the potential to impact every subspecialty. I think I've demonstrated that here, going from imaging all the way to interventional cardiology. But I think one of the important things to remember is that careful research needs to be done to find its efficacy and reliability in real-world applications. As we saw with the ECGs to screen for heart failure with reduced ejection fraction, sure, the results look really impressive when you looked at studies doing that, but when you actually put it out in the real world, it really didn't increase the number of patients you're finding. Similarly, a lot of this stuff is stuff that's accurately and well done by cardiology teams already. So in the real world, how much any of this stuff will change clinical practice or will have an impact on patient care is up for debate. And I think that's going to be the big next step. A lot of these models have already been developed and are there, but the big next step is going to be, okay, well, when we implement it in clinical practice, does it really make any difference, or is this just a lot of money and time spent for, to feel nice in terms of what computers can do? Here's my references. Again, I would say if anybody found this topic at all interesting, I would really say that #1 paper is a really good one in the American Journal of Cardiology, which sort of reviewed artificial intelligence and cardiovascular care. It went through all the subspecialties and different work being done. It says part 1. I didn't find a part 2, so maybe that's still upcoming in the future. I'm sure you could do infinite parts because of all the work that's being done right now. All right. Thanks so much for everybody listening. Happy to answer any questions.
So thank you, Hamza, for all your hard work and great review. And I would summarize it by saying that paraphrasing the Industrial Revolution, now we're in the Information Revolution 3.0. So the first one will be getting all the computers and pocket device out there that we can use electronic medical records. Step #1. Step #2 is the use of internet, where we get information very reliably. Now in 3.0, that is with the artificial intelligence, where the cognitive skills of human beings are being replicated and surpassed in many ways. So the latest IQ check on the ChatGPT 4 was actually around 130. So, and many studies have shown that the specialty exams are being beaten by the ChatGPT type large language models. So, you know, moving forward, it's going to be a very interesting world. When I give similar presentation, I would say the following, that I don't think AI is going to replace physicians. However, physicians who know AI well and use it well will replace physicians who do not use AI. So I think, in many ways, we need to keep up with what's going on. And like everything else, if you use the tool correctly, then we can benefit and improve our efficiency and save time so we can spend more time with more patient-facing activities. So I think that's where we're hoping to be. So Hamza, this is a great opportunity to have now that you just enter into the field of cardiology and with bright eyes. And how do you feel that now with information revolution 3.0 is going to impact your education and your future career?
Yeah, that's a great question. So in terms of education, I see a lot of value in it. When you talk about, for example, in terms of Echo, having AI software to guide you, in many ways that gives you the ability to do infinite practice, right? When you're on call, using point of care ultrasound to try to find good images. In the past, even as an internal medicine resident, what I do is get those images and then find the one or two internal medicine physicians who are interested in that and show it to them and have them review it. And it's always very difficult versus if I had AI software, to help guide me and do that work, it would be quite helpful. I do think there is a danger in education, though, which is letting it be a crutch for your work. We see this all over the place. You're supposed to always try to interpret your radiology images or chest x-rays before reading the report, but we just read the report. I remember I did medical school at Queens where I had to write down all my medications, and I knew the doses better than when I studied for my Royal College exam. Because I use EMRs all throughout internal medicine residency. So education-wise, it's a double-edged sword. It can really help you, but it can also hinder you, and then you'll find yourself in situations where you wish you didn't use it as a crutch. So you have to be careful, I think, about that. In terms of practice, I mean, sky's the limit, in terms of what this technology can be used for, in terms of making work more efficient, spending less time on charting. I mean, it would be beautiful if a AI software could do a chart review and I don't have to spend, half my time doing that. I can spend more of my time sitting with patients, asking them how they're feeling, what their symptoms are, and taking care of my patients. So practice wise, it's difficult to say how it's going to impact practice, but I think you're going to see it impacting it in various ways all over the place.
So when I spoke to many of the trainees recently, they've been using large language models to help them as their virtual tutor in terms of preparing for the specialty exams. So you can, put in the guidelines and summarize it, and also use it to actually come up with questions that are bot type questions, so you can practice on it. So I think, a lot of people are already using it, and I think it backs the questions of our, specialty exam planners as well as examiners to actually catch up to this. And I think, um, Royal College has some work to do in that direction. The other thing that is important, I think, from a training point of view, is that, I mean, the whole goal of the training process is really improve your cognitive skills and your experience in looking at all these cases, so you can develop a line of thoughts of critical thinking. And one of the risks is actually delineated by recent studies in teenagers as well as others, that if you use a lot of TikTok or use a lot of LLMs, you can develop a brain that is called TikTok brain, or large language model brain, where they do most of the work and you just follow it. And it's interesting to recall the history. And about 20 years ago, the graduation of Stanford class actually recommended their degree is actually a Google degree. So I bet you in the next year or two, one of the graduation class in the valedictorian speech is going to talk about the ChatGPT degree. because many of the students in universities are already using ChatGPT to do a lot of their work, from what I understand. So, any other questions from the audience? Okay. Sean, you came on. Any questions?
Yeah, thanks. Chiming, Hamza, a great presentation. I wondered about your thoughts on, and maybe this is a bit of a leading question, but the importance of looking at outcomes. There's a lot of association here as it relates to, diagnosis, and the potential for is there, obviously, for better outcomes. But AI is like a strategy, is it's a tool, like many other things that we have. And the argument has been that for devices and for pharmaceuticals and other ways that we manage our patients with cardiovascular disease, that randomized trials are needed before we make changes in our practice. So I appreciate some of what you described. It doesn't necessarily lend itself to randomized clinical trials, but do you think that we need to do some of that and look at potential outcome differences before we more in a widespread fashion adopt this sort of tool in, let's say, routine clinical practice?
Yeah, no, I completely agree with you that we need to look at outcome data. My eyes were opened by the one paper I put where, sure, they use this screening tool for ECGs to find patients with heart failure, reduced ejection fraction, didn't really change that much the number of patients they actually found, right? And so it looks really cool where you think, wow, from a 12-lead ECG, we can find these patients. But in the real world, is it making any difference? No. Similarly, you have the first paper I talked about with the arrhythmia classification with AI, sure. But in the real world, nobody looks at one ECG. You look at multiple ECGs, you look at the patient's clinical situation, you look at, everything all together to make a decision. And usually those decisions are more reasonable. You're not just looking at the one. And would it really make such a big difference if, you get one ECG correct and you looked at one and you thought it was AFib and it was actually a flutter. 5 minutes later, you get another one, you realize, oh, it's actually a flutter. So I agree that outcome data needs to be presented and shown before we start using this stuff, partly because it's pretty expensive right now with the amount of computing power required for AI, partly because there's a lot of money to be made by different companies, and it wouldn't be, I think it's not a good idea to be spending millions and millions of dollars in a limited resource healthcare system when we don't know if something is going to be really valuable. I do think ultimately, hopefully, this will show better outcomes for patients given the promise for it. And I think in theory, you could do a randomized control trial. Half the patients, this software was used, half the patients, the software wasn't used, and then see what happens. And certainly the money out there to do it. So we might be seeing more of that in the future. I think the biggest challenge is going to be the regulatory one. In the United States, the environment right now is very much against regulation for AI. I worry that without those sort of regulations, it gets widely adopted, and once the horse is out of the barn, it's really hard to put it back in, and then you're using stuff without even knowing how much it's helping you.
Great. Any other questions? You can put in the chat. So again, there's another interesting phenomenon about artificial intelligence is reports about radiologists increasing their anxiety because of artificial intelligence. The way it works is that now they have all these warning system that pre-reads your, let's say, mammogram. So then these system will actually put on a warning about these studies. So they have like a red light next to them, and then the radiologists will have to actually look through all those to see where the computer is thinking is the error. Sometimes the radiologists don't find it, and then that's actually increased anxiety, and that has been reported. The other interesting phenomenon that has been shown is training. So, right now, the radiology residents have to read, some of these studies ahead of time or pre-report them, but then they were all pre-reported by AI. So then the question is, how do you actually train future generations of trainees to be an expert level during the training when a lot of it is actually um, pre-reviewed by artificial intelligence? So can you comment on that, Hamza?
Sorry, can you repeat the question?
No, just the question of the danger of AI. So moving forward, apart from the regulatory issues and ethical issues in terms of training, because then the artificial intelligence can do all the work before the fellows or residents like get to the study. Like a good example will be ECG, because all the ECGs has been pre-read by the computer, not necessarily by artificial intelligence, but currently by Muse will be rule-based system. But how do we actually deal with training residents and fellows in terms of their diagnostic skills if
Yeah,
everything is read by AI already?
yeah, it's a difficult problem because we've already been dealing with this problem as a society for a while. There's tons of papers out there about how GPS has changed people's ability to be able to navigate areas. I grew up in Etobicoke. I can tell you all the streets there. I'm old enough. I was born in '95, where me and my uncle would use an actual map. I can't tell you the streets very well in Kingston, where I did medical school, or Hamilton and Kitchener-Waterloo, where I did internal medicine residency. And we used to think that being able to navigate was innate to human beings. And we found that it's not that much, and it's not that innate, and we can lose that ability. And so this opens up a whole can of worms where if you're using artificial intelligence as a crutch all the time in training, it does bring up this risk of how are you going to be ultimately in practice. A recent paper that I still think is in pre-publication, to be fair, but it did make a lot of rounds, was a paper where they had people write essays, and one group of used no AI in writing their essays, another group used artificial intelligence in writing their essays, and they found a considerable drop in ability when the group that used AI, and then they told that group, okay, now don't use AI and rewrite your essay. That group actually did much poorer in their ability to write, reasonably good essays. Versus, interestingly, the group that was told not to use AI, when at the very end they said to them, okay, you guys can use AI, they got even better. So we see both of that out there in terms of signal. One is, unfortunately, you can use it as a crutch, and then when you finally don't have that crutch, you're in bad shape. And the other one is you don't use it as a crutch, and then you use it as a boost. The problem, unfortunately, is how do you get around this? I mean, human nature is human nature. We look at EMRs all the time. Past medical histories have stuff in there that doesn't make any sense. It's copy paste through medications, that copy paste through notes, that copy paste through. We see that all over the place being done, even though we're told not to do it. We look at radiology reports without interpreting it ourselves. We look at ECGs without interpreting it ourselves. It's just human nature to do that. I don't know what the answer is in training. A simple one would be a trainee has to do so many of certain reports without artificial intelligence support. That would be the most simple way to force that. But the problem is, sure, you do that, and then once you're out in practice, if you decide to go back to the AI crutch, you'll lose those skills pretty quickly. So, beyond just hoping and teaching that there's a certain ethic that you should have as a physician, I haven't seen very good other explanations or answers as to how to get around this problem.
Yep. Okay, so without further questions, I want to thank Hamza for presenting this great review. There's a lot of philosophy or philosophical issues around what we are facing with in this information age revolution 3.0. But without, in my parting words, I would say the following, in quoting Professor Jeffrey Hinton in a recent television interview nationally. And when asked about what would you put your children or recommend them to do and trained in, and he said the following: a plumber.